आपका?
नाम देवलाल है।
देवलाल। अच्छा, क्या उम्र है आपकी?
ऐसी हुई 65-66
65 साल। अच्छा, कहाँ के रहने वाले हैं?
मडरा के।
मंडरा के। अच्छा, आप कब बिल्कुल ठीक थे? कितने दिन पहले ठीक थे?
मैं तो बिल्कुल नॉर्मल हूँ, सही हूँ।
हाँ।
ये तो 16-17 जुलाई थी परेशानी बनी।
17 जुलाई से?
हाँ।
17 जुलाई को क्या महसूस हुआ आपको?
मैं बताता रहा हूँ आपको, ऐसी शिकायत वही कि शरीर में हड़कल सी वही।
हाँ हाँ।
हड़कल होने के बाद में मैंने एक टैबलेट ले ली चाय के।
ठीक है।
टैबलेट चाय लेने के बाद में 15-20 मिनट बाद घबराहट सी हैगी, जैसे बीपी बढ़ जाता है। तो मैं थोड़ा लाइन से अलग हट गो, वहाँ जाके ठंडा पानी पियो, मुँह हाथ धोओ और बैठे रहो घंटा लगा के बाद में फिटे हो।
फिर उसके बाद
जी परेशान हुई। फिर शाम को आके मैंने अपना बीपी चेक करा, बीपी नॉर्मल करो। फिर 18 जुलाई को मैंने डॉक्टर राजीव पास ने अमृतनाथ सिंह हमारे, उन्हें बताई जी पोजीशन, तो उन्होंने दवाई दे दी बुखार की। दवाई दे दी बुखार की 3 दिन की। अच्छा, 1 दिन की दवाई खाने के बाद में, 2 दिन की खाने के बाद में बुखार को पेशाब जो पीला आ गया।
आपको बोलना कम पेशेंट भेजे,
पेशाब जो पीला आ गया। मैंने कि डॉक्टर साहब पेशाब पीलो क्यों आ रहा हूँ? तो फिर बोले उन्होंने और 2 दिन की दवाई ले जा, सही हो जाओगे। तो 2 दिन की दवाई और ले आए, परंतु पेशाब में कोई तब्दीली नहीं है।
Okay, so we are going to discuss about this patient who is having yellowish discoloration of the eyes and urine. So normally this patient was okay, as he says, about 2 months back, and he had no complaints. So one day he experienced weakness and he consulted a doctor who gave him some medicines, and after taking the medicines he experienced that he is having dark colored urine. So he consulted the doctor again and they investigated the patient and he was found to have jaundice. So he was advised some medical treatment. दवा लेने के बाद कुछ आराम हुआ आपको?
हाँ, फीवर में तो आराम है वो, परंतु
बुखार कितने दिन तक रहा था?
बुखार वही 2 दिन में सही है वो।
जाड़े के साथ बुखार आया था?
नहीं, जाड़ो ना लो,
सिर्फ बुखार आया था?
केवल बुखार, हरजुरी सी मारी सही है।
अच्छा, उसके बाद
में तो मैं दवा ले ली, तो दवा तो 2-3 दिन में सही है वो बुखार तो, परंतु ये पीलिया की शिकायत बनती चली गई।
he says that he had fever also for 3 days with no chills or rigor, and the fever subsided on its own, following which he said that the jaundice, initially the urine color was dark and then it became dark yellow, and then he also experienced change in the color of the skin, and it was starting from the eyes, now it has gone to the whole body. तो अब ये पीलिया बढ़ता जा रहा है आपको?
हाँ,
अच्छा,
बढ़ता ही गया है। 1% जीना है कि डाउन हुआ है,
कभी कम नहीं हुआ?
नहीं।
अच्छा, और इसके साथ वजन कुछ घटा है या कमजोरी भी आई है?
वजन तो कम डाउन है वो।
हाँ।
वजन मेरा फिलहाल मैंने फीवर की दवाई ले गई तो 53.5 किलो।
पहले कितना था?
उससे पहले तो काफ़ी पे वो ऐसे 59.5 किलो।
He was having weight of around 60 kgs, but then recently he had a weight record which was 53 kgs. So ये 7 किलो का वजन कितने दिन के अंदर कम हो गया आपको?
ये एक हफ्ता के अंदर कम है।
He says it is within 1 week, although that may not be true, but expecting that in 1 month he had a loss of weight of about 7 kgs, which is very significant. So now from the history, और टट्टी कैसे रंग की आती है?
टट्टी ऐसी आते सब मटीले से रंग।
मटियाले रंग की। ये कब से आ रही है टट्टी मटियाले रंग की?
ये जब से आई है जी, ये फीवर
जब से पीलिया बुखार हुआ था उस वक्त से। So he says that from the time he had fever and yellowish discoloration of the body, he also has clay colored stools, और खुजली मचती है बदन में, पूरे बदन में खुजली मचती है, which is itching. कभी काले रंग की टट्टी तो नहीं आई? काले रंग की टट्टी नहीं आई। So when you take the history, these are very significant things, that patient has loss of weight, भूख लगती है.
हाँ भूख थोड़ी बहुत है.
He has loss of weight, he has loss of appetite, he has itching, and he has clay colored stools, and there is progressive yellowish discoloration of the body. So all these points point towards the derangement of the hepatobiliary system, and that is the main purpose of taking a history. And the type of jaundice which is from the history we infer is that it is likely to be an obstructive jaundice, because in obstructive jaundice there is itching and there is clay colored stools. Sometimes there may be bleeding per rectum also, but that is not there in this case. So basically from the history we gather that he has jaundice which is progressive, and this jaundice is likely to be obstructive in nature because having itching and he is having clay colored stool, and the disease is progressing also. He is also having loss of weight and loss of appetite. So with this history we will go for the examination. So from the history we infer that the purpose of taking history is to know which system is involved. So in this case, from the history which we gather so far, it is very clear that it is the hepatobiliary system which is involved, and it is a progressive disease. That means it is something very serious, that the disease is not normally in jaundice. Many a times it happens that there is a jaundice for some time and then after some time it wanes. So that is usually seen in viral hepatitis or jaundice which is not obstructive. So in this case it is a progressive jaundice. So that means there is an obstruction which has not been relieved, and hence he is having this type of jaundice. So now we will do the examination and find out what are the regions, and first we will do the general examination. In general examination we have to first see the skin, and of नीचे देखिए there is yellowish discoloration of the sclera. ऊपर देखिए it is involving the whole of the bulbar and palpebral conjunctiva. जीभ दिखाइए, there is tongue is coated and oral hygiene is also poor. अंदर कर लीजिए. Then we have to see the lymph nodes. गर्दन झुकाइए, गर्दन झुकाइए. So this is the transverse chain, submental, submandibular, preauricular, postauricular. There are no lymph nodes palpable. Then you have the jugulo-digastric, then you have the jugulo-omohyoid, and then it is the supraclavicular. It's important in this case to see for left supraclavicular lymph node. So if they are enlarged, they are very significant because they indicate there is some pathology in the stomach or abdomen which can have a metastatic spread into the left supraclavicular lymph nodes. So there is no significant left supraclavicular lymph node. Then we do the axillary examination and we try to find out whether there is any lymph node in the axilla. This side. No significant lymphadenopathy. Then we will see, of course, vitals have to be seen before we do that. Pulse, blood pressure, temperature, respiratory rate. So all that appears to be normal. What is important is now we will see for clubbing. You see, his nails are. ये नाखून में क्या हुआ तुम्हारे?
ये पहले से खराब हो गए 2-3 साल तक.
अच्छा, he has some fungal or some
फिंगर.
fungal infection in all the nails.
ये तो सही है.
So there is no clubbing or cholinicia. What is important is in a jaundice patient we look for clubbing, but there is no significant clubbing. But there is nails are not normal. They are having some form of infection, maybe fungal infection, and there is no palmar erythema, although there is some yellowish discoloration of the palms. And then we see the abdomen. The abdomen is also having some yellowish discoloration hue. We will come to the abdominal examination later on. And then we see for the groin nodes. And then we see for the pedal edema. There is no pit edema. So that general examination is only positive is obstructive jaundice, that is the yellowish discoloration, which is moderate to severe jaundice is there, and of course there is no clubbing or cholinicea, except there some nails are not normal, maybe having some fungal infection. No lymph node enlargement and no pedal edema. Now we will do the abdominal examination. On inspection, the abdomen is scaphoid. There is no lump seen. Respiration is normal. No visible peristalsis, no visible pulsation. Umbilicus is central, not stretched. Hairline is normal. There is no scar marks or no itching marks on the abdominal wall. So now we do the palpation. लंबी लंबी सांस लीजिए. So there is no splenomegaly. Right iliac fossa is normal. Now सांस लिए. Yes, I can feel the liver coming and strike my fingers. सांस लीजिए. So it is around 4 centimeter below the costal scale now. So there is moderate hepatomegaly, not clearly palpable gallbladder, but maybe in the enlarged liver it may be under that surface, and there is no lump in the epigastrium or in any other part of the abdomen. We like to see what is the liver span. Second, third, fourth, fifth, sixth, seventh. So there is some resonance in the fifth and sixth space. That means either he is having some hyperinflated lung, or there is descent of the liver. So here it is resonant in the sixth space, and it is dull in the fifth space, seventh space. This is again dull, 8th, 9th, 10th. It is resonant. So the mark which we have to make is so this is the length of the liver. It is going about 3-4 centimeter into the abdomen, and the whole right lobe and the left lobe both appear to be enlarged. थोड़ा निशान बना रहे हैं पेन से, ठीक है? What you got here? It is around 13 centimeters. It's not significantly enlarged, but it is definitely having descent. And this is the costal margin. So there is hepatomegaly, but mild hepatomegaly I would say, because the liver span is only 13 centimeters. This is the liver span, is 13 centimeters. So and it is non-tender. Margins are sharp, well defined, and it's non-tender, and no nodules are palpable in the liver. And the gallbladder is very difficult to identify. Maybe it is under the surface of the liver, so we cannot do that. So that is there, and there is no other we need to do a PR examination also to confirm whether it is clay colored stool is there, or there is hematochezia or melena. So with this और कोई सांस लेने में कोई परेशानी है? So we have to do the examination of the other systems also, cardiovascular system, respiratory system, and genitourinary system. So these systems have to be completely examined, because if there is a disease of jaundice, it may affect any of these regions. So now we have done 3 stages. First, we have taken the history. Then we have done the general examination and local examination. Then we have done the systemic examination. And now we have to analyze all the findings of the history examination and make a provisional clinical diagnosis. So the positive findings in history is that patient is having progressive jaundice,
Painless.
and she's got a urine which is dark yellow in color, and he's having weight loss, he's having itching all over the body, he's having clear colored stools. The findings on examination, of course, according to him, there is weight loss, and it is 53 kgs. Initially, it was 57 kgs, so there is loss of weight. And the other positive finding is that he's got severe jaundice, and the jaundice is not only localized to the sclera, it is to the palms, soles, up to soles also there is some yellowish discoloration, so there is severe jaundice. On palpation of the abdomen, the only positive finding is there is, and you have to see for ascites also. It's all resonant. So there is no dullness. So that means it is all, there is no ascites. And that is why we are not doing shifting dullness, because if there was some dullness in the end, that would mean there is a fluid. But on percussion, there is no fluid, so it is shifting dullness and is absent. And hepatomegaly is also there, but it is not very significant. It is not hard in consistency, it is not having nodules, and it is non-tender. So when we compile all these things, we come to the conclusion that this patient is suffering from obstructive jaundice. Now this obstructive jaundice is progressive. So, and the gallbladder is not palpable. Because in some, we have to first discuss the causes of obstructive jaundice. The obstructive jaundice causes are mainly carcinoma head of pancreas, then there's cholangiocarcinoma, then there's the periampullary carcinoma, and sometimes gallbladder carcinoma with metastasis at the porta hepatis. These are the major causes. And benign causes also have to be considered. The most important benign cause is CBD stones. So, first of all, we have to say from the history, is obstructive jaundice is of benign origin or is of malignant origin. So, a history of severe pain in the right hypochondrium radiating to the back and shoulders, which is recurrent, is an indication that it is probably a benign cause, because usually there is a gallbladder stone which slips into the CBD, and then there are recurrent multiple attacks of pain. So that would lead to obstructive jaundice. So in this case, that typical presentation of a stone in the CBD and multiple attacks of cholecystitis is not there. So that means it is very unlikely to be a case of a jaundice because of stones. The other cause is simple progressive jaundice. Now, simple progressive jaundice is typical of malignancy, and most commonly it is either because of carcinoma head of pancreas, because they slowly the compression of the CBD takes place, and gradually the jaundice keeps on progressive. So in this case also there is progressive jaundice, but the only thing which happens is that there is a palpable gallbladder, which is through the Coviser's law. In the Coviser's law states that if the patient is jaundiced and the gallbladder is palpable, it is not because of a benign disease. In this case, gallbladder is not palpable. So that means it is not fitting into the typical presentation of carcinoma head of pancreas. Periampullary carcinoma also has a similar picture, but there is waxing and waning of jaundice, but it's only present in 10 to 20% of cases. But again, the gallbladder will be palpable and tense. which is not there in this case. So the gallbladder is not palpable and there is no waxing and waning of jaundice. So again it is very unlikely to be a case of periampullary carcinoma. Then comes the cholangiocarcinoma. So cholangiocarcinoma, again it has a typical picture that if the cholangiocarcinoma is in the lower CBD, then again the gallbladder will be palpable, because that will be causing back pressure and cystic duct dilatation leading to gallbladder distension. So again, it is not likely to be a cholangiocarcinoma arising below the cystic duct junction. However, it can be proximal to that at the bifurcation or somewhere else. So again, that is a clad skin tumor, which is a rare phenomena. It's not so common, and hence we would not keep that as a first diagnosis. So then the fourth important thing in this case would be carcinoma gallbladder. And since it is an endemic area where carcinoma gallbladder is a common presentation, we have to keep that possibility as a very important differential diagnosis. In this case, it can be explained on the basis of the pressure at the porta hepatis. So the gallbladder cancer is growing and metastasis is there at the porta hepatis, which is causing pressure of the CBD, and the CBD is compressed leading to jaundice. And this compression, as it keeps on progressing, the size of the lymph node, and it keeps on pressing upon the CBD, which leads to proximal dilatation and obstructive jaundice, and it is a progressive disorder. So now the last thing which we can conclude from this history and examination is that probably it is, and there is hepatomegaly. That is also because if the gallbladder carcinoma is there, it can invade the liver surroundings and it can metastasize directly by invasion or by metastasis, hematogenic or lymphatic. So all the three modalities are there in carcinoma of the gallbladder, and that is possible in this case, as the gallbladder is not palpable but the liver is enlarged and there is obstructive jaundice, which could be pressure at the porta hepatis. So now, after analyzing the case, we can come to the conclusion by history and process of exclusion that this patient is possibly a case of obstructive jaundice due to carcinoma gallbladder with secondaries at porta hepatis. So now once we have this diagnosis, we have to analyze the case, how we go forward for the investigation and management. So the first important investigation in this case would be to have an abdominal ultrasound. So abdominal ultrasound would sort out one very important thing: what is the region, where is the pathology primary, and what is the status of the bile ducts. Are they dilated or they are not? And is localized to one lobe or to both the lobes are involved. So ultrasound of the abdomen has been done in this case, that we will discuss. Then liver function test. Liver function test will tell us direct, indirect, and how much is the serum bilirubin. So that will tell us about the magnitude of the obstructive jaundice, and accordingly we have to manage that. Then other investigations like prothrombin time, INR, these are also important because any intervention which we do will need to have coagulation factors which are normal, otherwise there will be bleeding during interventional procedures. So these are the very important investigations, and after the basic CBC and LFT and RFT, we will go for more sophisticated investigations such as MRI or CT scan or both, depending upon the findings on ultrasound. So ultrasound is a very important investigation at this point of time, which will tell us how to move forward with the investigations. And liver function test will tell us what is the current status and how to manage this patient. I think this much will show you